Hello, I'm Dr Louise Newson. I'm a GP and menopause specialist, and I'm also the founder of the Newson Health Menopause and Wellbeing Centre here in Stratford-upon-Avon. I'm also the founder of the free Balance app. Each week on my podcast, join me and my special guests where we discuss all things perimenopause and menopause. We talk about the latest research, bust myths on menopause symptoms and treatments, and often share moving and always inspirational personal stories. This podcast is brought to you by the Newson Health Group, which has clinics across the UK dedicated to providing individualised perimenopause and menopause care for all women. So today on the podcast, we're going to talk about fibroids, something that's very common, and often people have lots of questions, both on social media and in my clinic as well. So I've got the great privilege of having Osama Naji with me, who has been talking on my podcast before about bleeding especially on HRT. So that's a great podcast to listen to. So I've invited him back again. He's a leading gynaecologist in London. We do a lot of work behind the scenes, including some research together. So welcome back to the podcast today.
Thank you so much for having me again, Louise. Always a pleasure to talk to you.
So fibroids, let's just get straight into it, really. They're really common. Different papers I've read have said different things. Some say 2 out of 3 women, which is a lot. So the majority of women have fibroids. They're more common in certain races and certain ages of women. But let's go for it. What are fibroids?
Lovely. Thank you very much. Thanks again for having me. I'm delighted to be with you today. You will find the next few minutes we are going to talk to be useful, informative to your audience and to your team as well. So fibroids are common benign tumors of the genital tract. In particular, they belong to the muscle layer originally from the uterus. They are very common, like we said, and we will try and we call it explain it in very simple terms, so they can make
perfect
about their symptoms, their potential problems, as well as what are the available solutions for them. So fibroids are very common. They are particularly increasingly common recently because we are getting better to notice them, and patients are also more aware of them. So when they report any unusual symptoms, quite often fibroids get picked up during routine examinations, during routine imaging from accident and emergency department visits. And, when a woman presenting for some non-specific pelvic pain or abdominal pain related initially probably to a renal tract, abdominal problem, and then, oh, by the way, there is a fibroid here. So therefore, they manifest not in a very straightforward symptoms unless they are reaching a certain size and a certain number. But to simplify it, these fibroids are affecting approximately maybe 1 in 4 to 2 in 4 women. And they tend to trouble the woman in a spectrum of 4 main symptoms. So, heavy menstrual bleeding. Number 2 is abdominal pain. Number 3 is pressure symptoms. And pressure symptoms, I mean, because the uterus is located in the pelvis, surrounded by other pelvic organs, primarily the bladder in the front and the large bowel in the back. So it depends on their location. These may exhibit some pressure symptoms, and therefore we call it indirect manifestation of these fibroids. So that's number 3. And number 4 is infertility. However, the woman may struggle with 1, 2, 3, or all of them, or none of these symptoms, depending on 3 factors: the number of the fibroids, the size of these fibroids, and the location of these fibroids. The uterus is a very sophisticated pelvic organ, has got 3 layers in particular. So therefore, the fibroids could interfere with the outer layer, with the inner layer, or the middle layer. So it depends on their location. Go towards the top part of the uterus, towards the lower part, or towards the middle part. So therefore, location is crucial to understand the symptoms of these fibroids. And therefore, we call it fibroid mapping. Based on the fibroid mapping, we can tell and connect the dots to which symptoms I keep saying it to my patients. Every fibroid has got a single own story. There is no standardized
Yes.
treatment. So, and it is unfair or unjust to the patient or to the pathology to standardize a universal approach for it.
Mm. I think that's really, and it's very similar, as you know, to menopause and perimenopause. Everyone's individual and have individual symptoms, but certainly a lot of women I see have had a scan for another reason, or maybe because they've had bleeding, and then the fibroid's found. And sometimes people will say, well, the bleeding is because you've got a fibroid. And it might not be, or they might have urinary symptoms, and it might be because they've got some genitourinary syndrome of the menopause related to low hormones. And it's not the fibroid, because you do the look at the scan report, and the fibroid is very small, and it's nowhere near the bladder. You think, well, how can that be pressing on the bladder? So it's really important, isn't it, to, if you have fibroids, actually know exactly whether you've got one or more or where they are is crucially important, isn't it?
100%. So it is that's a very useful, good point you highlighted, Louise. So abnormal uterine bleeding is one of the very commonest gynecological presentation. And to reassure your audience and the patients in general, the vast majority, 60 to 70% of the causes of abnormal uterine bleeding is called functional. Is due to an element of transient hormonal imbalance between the two guardian angels of the reproductive system, which is estrogen and progesterone. And this mechanism could be disrupted to a variety of reasons, but we call it functional. And the remaining 20-30%, we call it organic. And the fibroid comes on top of this. So, but other causes could be ovarian cyst, could be polyps, it could be fibroid, and could be endometriosis. So therefore, the picture often sometimes correlate. You have a mixture of functional bleed as well as organic bleed. But the sensible approach, before we blame it on the functional part, it is prudent to exclude organic parts to make sure when there's nothing going on. This is probably a little bit of hormonal imbalance and can always be adjusted, self-resolved once we remove the root cause for it, whether it is stress, whether travel, whether bereavement, whether exams. These are the common triggers for transient hormonal imbalance. And once we exclude that, then we can safely blame it on that part. But if it is confirmed a fibroid, then people will probably need to talk about the mapping of these fibroids. And like you said, very right, if the fibroids are too small, they are unfair to be blamed for whatever symptoms presenting at the time.
Yeah. And do most people have one fibroid, or is it more common to have more than one?
Again, so a very good point. So fibroids generally tend to come like a solitary, and they tend to grow, or multiple small scattered ones. And it is very difficult to expect which type. It depends on environmental factors. It's also a lot of research highlighting the ethnicity, for example, of the patient. For example, women with the Black Asian ethnicity, they tend to have a little bit on the larger size of the fibroids, and while white Caucasian women, they tend to have probably smaller but multiple fibroids. So it's not easy to predict how many fibroids will. It's just generally they are common, but on different type, on location, it's most of the times it's individualized.
And do fibroids get bigger or smaller, or do they change in size when people become menopausal?
And again, so now this is important simply because fibroid, they love estrogen. They have estrogen affinity. They depend, they strive, survive, and start to cause more problems when there is a lot of estrogen. And the woman during their reproductive lifespan, there is a lot of estrogen in the circulation, and these fibroids, they take advantage of that, and therefore they start to exhibit more problems. So naturally, when you reach the age of the menopause, it is reasonable to predict that fibroids will start to behave themselves. They will not cause many problems. In the vast majority of cases, they remain to be, because every single tissue in the body, there are precursors to turn cancerous, but it depends on various aspects, various risk factors. Fibroids, reassuringly, so far, they are benign tumors, but in a very small teeny minority from them, about 1 in 5,000, particularly after the age of 50, they could turn into sarcoma. And sarcoma, because we are honored, privileged to work in a cancer center, we see maybe a little bit more of these sarcomas because we are probably a tertiary referral center. And I can say a couple of warning signs when suspected fibroids to exhibit sarcomatous behavior. Number one, generally towards the mid-40s plus and above. And when you notice a very rapid exponential growth in the pattern of this fibroid, so you can tell the woman that I've noticed my tummy is getting increasingly bigger within a very short period of time. And you will notice also a very sudden onset behavior in the change of the menstrual bleeding or pain or the pressure symptoms, because these fibroids, when they grow, they grow the problem with it. So therefore, everything will be exaggerated over a relatively short period of time. So therefore, this is a warning sign. Please be advised that this warrants a little bit further checks by certain form of imaging. So to answer your question, towards the middle, they tend to settle, more or less.
So, and that's interesting, because often, as you know, we see a lot of people who have been found to have fibroids. They may or may not have symptoms with them, but they're told they can't have HRT because of fibroids. And obviously, if someone's got a womb, we always give progesterone. And I have read some information that, you know, progesterone can be very beneficial at reducing the growth of fibroids as well. So I know that you're in agreement, I presume you still are with me, that people who have fibroids can still usually have combination. When I say combination, I mean estrogen with progesterone and testosterone if they need it, HRT. There isn't good quality evidence that having the right dose and type of HRT will be detrimental to fibroids.
100%. Please, this is a fact to reassure your audience and your team. Fibroids are not contraindication to prescribe HRT. So to this fact, there is no harm from prescribing. The only fact is, for asymptomatic fibroid, this is more applicable. For symptomatic fibroid, it is probably useful to warn or to advise the patient that this, although it's not contraindicated, but beware, because we are giving you estrogen and progesterone, this is a balanced dose, not unbalanced. However, fibroid may not like it. So the only way is to start and see what difference that will make. Based on that, after that, because the HRT has several other benefits, so therefore we need to balance. If you are experiencing some side effects, like the fibroid started to wake up because of this HRT, what is the balance of continuing controlling vasomotor symptom, improving cognitive function, increasing the energy? Are these the benefits worth to me to continue on the HRT while I'm there with the side effects of these fibroids? And that's where the like a very consolidated counseling advice. It's open discussion between the clinician and the patient, you know. So
absolutely,
yeah.
And I think, I mean, this goes back to anything in medicine. We can never say everybody can or everybody can't, and everyone is the same pattern, because everybody's different. And and which is really important. But also, like, you know, a lot of women, when they start taking HRT or their dose of HRT has changed for the first 3 to 6 months, they can have bleeding. And then if they have an investigation and found a fibroid, it's very easy to blame the fibroid. So it's really important in anything in medicine that we make sure we know what the cause is. But also, I do see a lot of women who have had fibroids, they know they've had fibroids, they might or might not have caused problems in the past, they might have settled down when they're menopausal, and they might have had resurgence of symptoms. But I'm surprised that there are still quite a few women I see who've been told that they can't have treatment, but there is treatment for fibroids, aren't there? Do you mind explaining what different treatments are available for fibroids?
Thank you. Yeah, absolutely. So if we stick back to the original equation we discussed, fibroids, 4 potential symptoms: bleeding, pressure, pain, and maybe infertility, although maybe some applicable, less applicable to some patients. And the other factors, number, size, and location. So we have to connect the dots with the current symptoms of the patient to tailor the treatment. And the treatment in general, by do nothing, an approach and just monitor, or medical, or surgical. And it's always we have to display the entire clinical picture to the patient, explain the risks, benefits, advantages. So that, like we discussed before, it's difficult to standardize like fibroids surgery, fibroids medicine, tablets. It doesn't work like this. Every single patient is its own story. Every single fibroid is its own story. So therefore, the idea is we have to first get the fibroid mapping and match it with the symptoms so that you can tailor the treatment, taking the patient's wishes, taking the patient's preferences on board, and then we can always tailor our treatment.
Yeah, and it's interesting, isn't it? Lots of women and men actually know their bodies really well. And I've had some patients over the years who have always had a fibroid and they're aware that it's there. And then when it's removed, they just feel so much better. And it's almost like, especially when they've got bigger fibroids and they can cause some dragging sensations or, like you say, some bladder problems. And they've sort of put up with it. And it's like anything, really. It's like having a toothache. It's not until you've seen the dentist you realize how bad that toothache is. And so for some people, they're not causing any bleeding, they're not causing any pain, but they might just be causing some discomfort, because fibroids can get quite big for some people, can't they?
Yeah, absolutely. Yeah, that's why they could be reaching, like we compare the size of the uterus when there's a fibroid by the size of the pregnancy. So when we do the clinical examination, equivalent to 16-week size uterus, a 20-week size uterus. We see patients, we call it full-term size uterus because of the fibroid. But another narrative is, for example, I have a special interest in fibroids. That's why it's a dear subject to me. So patient I saw recently troubled with fibroid, and it is deemed suitable for surgery, for some form of surgical intervention. So what we explained, again, we put the mapping, we put the clinical symptoms, we marry them, we form a clinical judgment, and therefore she said, okay, what's the treatment now? I told her, based on these factors, surgery. However, so are these symptoms to you troubling enough to justify surgery? Surgery doesn't come easy, although surgical gynecology these days now is reached very, very advanced, safe levels with enhanced recovery, with lots of skills, experience, equipments to make it a sophisticated type of surgery. However, still a risk. You are going to general anesthesia or you are going under local anesthesia. It's a surgical intervention. So the question is, now having known the problem, now having known the treatment, this is your decision you need to make. Is the problem enough troublesome to me to go for surgery? Quite often they said, now I know, now I'm reassured, I can put up with it. Let's see how I go. Let's see how much I can cope and avoid surgery, or vice versa. So
yeah, and it is weighing up that individual risks and benefits, like we do for any treatment. And sometimes people have what we call surveillance, where, like you say, you might monitor and do the scan every 6 to 12 months and see if it changes at all, or if symptoms change. And even like for you mentioned about could affect fertility. A lot of them don't affect fertility depending on where they are. But if someone did get pregnant with a fibroid, if the position is okay, it's not going to affect the pregnancy detrimentally, is it?
At all, absolutely. So, this is hugely important when it comes to fibroid and infertility. Not every fibroid causes infertility. prepare to this way. Fertility is a multifactorial, multifaceted approach. There is in the female, which I often explain, it's a very sophisticated system. We are very shallow compared to you guys. So they've got an ovarian factor, there is age-related factor, there's ovarian reserve, there is tubal factor, there is uterine factor, factor. So the fibroid belongs to the uterine factor, which is not the most common type of the factor, of the fertility compromising factors. So only the fibroids that of reasonable size, of reasonable proximity to the endometrial cavity, to the uterine cavity, they could potentially interfere with fertility. On the other hand, if conception happens spontaneously when there is fibroid on board, then this will trigger probably consultant-led obstetric care, because these fibroids may trouble the baby, they may trouble the embryo, they may cause miscarriage, they may cause early labor, they may cause antepartum hemorrhage, postpartum hemorrhage. So that's why, again, depends on the number, on the location, and on the effect of or some fibroids, they are way away from the action point, and therefore they can just simply be ignored.
Yeah. So the important thing is being monitored and assessed, and certainly by someone who understands fibroids is crucially important. And there are some clinics that do this embolization, don't they? This uterine artery embolization. Can you explain what that is?
Yes, thank you. Embolization is now has been in clinical practice in excess of 20 years. It is improving as well. It's a non-invasive method. It's offered by interventional radiologists. And luckily, there are several of them who are very skilled in this procedure. It's basically a procedure without a general anesthesia and aiming to block the blood supply, supplying the uterus entirely. And the aim with it is to attract the reduction in the blood supply to the fibroid, and therefore you would expect the fibroid to shrink in size. And the idea is to achieve a satisfactory reduction by at least 30 to 40% of these fibroids. They are not designed to make the fibroid disappear at all, but they work in certain criteria. There are certain indications for it. For example, ideally you would need the fibroid to be sizable enough so the shrinkage can be noticeable enough. Fibroids who are 2-3 centimeters, there is little value from this intervention, and there is little value from any intervention for them. While fibroids that are 10 centimeters and above, these are the fibroids that could potentially respond satisfactorily and reduction in size. But the other parameters is fertility wishes as well. The other, if the woman is desiring fertility, so maybe embolization needs to be counseled thoroughly, although now there are reported cases for successful pregnancy after embolization. These need to be counseled very, very carefully with the risks and benefits of future implantation, future ongoing pregnancy, live birth. And finally, again, women who are deemed, for any reason, at high risk for surgical intervention, or not safe to have surgical intervention, or they don't prefer to have a surgical intervention. This could be a happy medium. They have a large fibroid that is troublesome enough to require some form of removal, but the surgery is not desired or not advised. Then the embolization will come as a reasonable option with it. Obviously, as an intervention, it comes with its own consequences, side effects. There is the fibroids may not respond to it. Most of the times they do. There's a small proportion they may not. They may probably need more than one embolization session in the future, although very small minority. And there is also a sequelae, we call it post-embolization syndrome, which is the fibroid undergo exaggerated level of necrosis and ischemia, and they could cause variety of symptoms, including bad infection, including requiring emergency surgical intervention. But these will be counseled thoroughly, adequately, reasonable by the specialist radiologist who is performing them.
So there's lots of options, and it's great talking things through because there has been so much confusion, and I often get a lot of messages from people asking about fibroids, but it's particularly reassuring about the whole HRT question and fibroids, because that is really good for people to listen from a leading expert. So we have written an article together that's on the website, but also it's on the Balance app as well, that we've written so that people can understand more. So it's great going through everything. Before we finish, I always ask for 3 take-home tips. So 3 things that if a woman has just recently been diagnosed with fibroids, what are the 3 things that she should find out which will help her to lead and have a shared decision-making regarding her treatment going forwards?
Thank you very much. So let me summarize it in 3 points. Number 1, be assured fibroids are benign conditions. So without attracting anxiety, panic about it, they are very common. Most of the times are treatable. They are most of the times can be harmless. Just being aware of them is what we need. But therefore, seek the right fact about it. Fibroid generally needs to be mapped by an ultrasound scan. If they are of substantial size, they may need other forms of imaging modality. So know the facts. Knowledge is power. When you understand the fact, your judgment will be better. Your clinical decision will be better. And the patient decision will be better. So establish the facts of these fibroids, number, location, size, and this is often available by ultrasound scan. And seek professional guidance and advice about managing of these fibroids. Most of the times, do nothing approach is all what you need to do. And this is fact number 1. Fact number 2, HRT are safe in fibroid. They are the benefits of it way more the risks, and the fibroids are not interfering with this equation. Only in very small minority, when the baseline before starting HRT, fibroid are diagnosed to be causing problem. And even in that scenario, fibroid HRT may worth trying because they may not disrupt this problem at all. They may make it a little worse. And fact number 3 about sarcoma. Please be aware that if you experience rapid growth in the fibroid, accelerated exhibition of the symptoms of the problem of the fibroid, just be aware there could be a small teeny tiny risk of abnormalities in there.
Excellent. So know your bodies, know your symptoms, make sure you know when to receive help, and make sure that you are part of this shared decision-making process so you can choose the right treatment, or there might not be any treatment that's needed. So thank you so much for your time. It's been really informative, and I'm hoping very enlightening and reassuring for a lot of people listening. So thank you.
Thank you so much, Louise. Pleasure.
You can find out more about Newson Health Group by visiting www.newsonhealth.co.uk. And you can download the free Balance app on the App Store or Google Play.